My name is Julie Duppheid from the University of Southern California in Los Angeles. It is my pleasure to speak with you today about attention deficit hyperactivity disorder. We're going to talk about treatment and comparing treatment options, but first we're going to take a look at disparities in the diagnosis and treatment of ADHD in minorities. My goal today is to cover these three learning objectives: addressing treatment disparities in minorities, comparing pharmacological treatment options with regard to pharmacological profiles, adverse effects, tolerability, and most importantly, perhaps, counseling techniques and information that should be reviewed with parents and families. Now, symptoms of ADHD are typically first noticed in the classroom. This picture is an example of a classroom with well-behaved children. They're raising their hand to answer a question. Well, frequently, parents may not recognize that their child has symptoms of ADHD or recognize whether they're developmentally appropriate or inappropriate until the teacher brings it up and notices that this child is not able to wait to respond. They blurt answers out. The child cannot sit in their seat. They're not able to complete an assignment. They're not able to pay attention. They may have behavioral problems. And in 2011, the American Academy of Pediatrics published its latest guideline on the diagnosis and treatment of ADHD. And the American Academy of Pediatrics is recommending that whenever a child age 4 through 18 is having impairment in learning, impairment in social development, then they need to be evaluated for attention deficit hyperactivity disorder. It can start as early as age 4 years old. So the diagnostic criteria for ADHD is important for pharmacists and all healthcare professionals to know. It's not something that should be taken lightly. Your child's hyperactive, your child can't pay attention, they may have ADHD. But really, you need to look at the number of symptoms, look at whether the symptoms are predominantly inattentive or whether they're predominantly hyperactive impulsive. There needs to be 6 of 9 symptoms in elementary school age children, only 5 symptoms in older adolescents and adults. And the symptoms need to be present in multiple settings, at school, at home, for most days over a 6-month period. So the child needs to be assessed by teachers, by parents, by extended family members. And there are rating scales that we'll go into later in the presentation that can help objectively rate these symptoms. It's important to look for learning disabilities, comorbid conditions such as anxiety, depression, or even autistic spectrum disorder to determine how much of an impact the comorbid condition can have in the symptom presentation and to make sure that treatment is taken into account for that comorbid condition. An analysis of 17,100 children, kindergartners, was conducted by the National Institutes of Health, and it was a representative sample from across the United States. And what was found is that when children were assessed by teachers and parents, 1st grade, 3rd grade, 5th grade, 8th grade, that there was significantly lower diagnosing for African American, Hispanic, and other ethnicities compared to white or Caucasian children. And ethnic minorities were not only less likely to be diagnosed with ADHD, they were also less likely to be prescribed ADHD medication. And this can impact their growth and development, their learning, their development of self-esteem, if ADHD is not recognized and treated in the child. It certainly can have deleterious outcomes. This graph plots the likelihood of a diagnosis of ADHD by race or ethnicity. You can see that the X's are white children and the diamonds are Hispanic. The triangles are other races, ethnicities such as American Indian, Asian, Pacific Islander, and the square line is for Black or African American children. And it's very clear that ADHD is diagnosed much more frequently in Caucasian children compared to other ethnic minorities. And there is a peak in diagnosing ADHD in the third year of school. Third graders have the most predominance of new onset diagnosing of ADHD. And by the time in 8th grade, the child symptoms may become fewer, symptoms may still be impairing, but you still see the disparity in diagnosing based on ethnicity. This next graph just shows the cumulative proportion not diagnosed with ADHD. And it shows the disparity in just a bit of a different way. You can still see that African Americans, Hispanics, and other races and ethnicities are not diagnosed with ADHD, and it looks from kindergartner to the 8th grade. There are many reasons for a lack of diagnosing and treating ADHD in ethnic minorities, and many of these are cultural and society differences and barriers. And these are outlined in the Diagnostic and Statistical Manual of Mental Disorders, which is the textbook that is utilized to categorize diagnosis of neuropsychiatric disorders in youth, developmental disorders such as ADHD. In some cultures, being hyperactive and impulsive is considered just part of being a boy. Some cultures believe that discipline or a firm hand is all the child needs. Many cultures are concerned about their child being labeled with a psychiatric diagnosis. And there is concern among all ethnicities about the child becoming a drug addict. I've seen this in my practice in Los Angeles County dealing with ethnically diverse populations where pretty much Caucasian and Asian, African American, Hispanic, they're pretty much all concerned about what treatment might do to their child. But it is clear that not treating ADHD can do more harm to the functioning and the learning and the growth of a child than recognizing and treating ADHD. Now, in some cultures, there are many families living at home with the child. They may have grandparents, aunts, uncles, multi-family homes, and then these families can have influence on whether the child is taken for evaluation and treatment. And in some cultures, there is a distrust of psychiatry or psychology. And in a multinational study by Polancic that I've cited on this slide, language and communication barriers can impair and impact the referral for diagnosis for ADHD, and sometimes communication with the healthcare provider. If the provider does not speak the language of the parent or the family member, they may not be able to convey the child's symptoms. Now, it was once thought that ADHD was a condition pretty much found in North America and Europe. Based on, you can see this slide shows that most of the studies on the epidemiology of ADHD was in North America and Europe. But when an analysis of 102 studies from 171,000 youth from 7 regions across the world, when experts on ADHD looked at the criteria used to diagnose ADHD, they found that when similar criteria was used, that rates of ADHD were similar in these different regions at about 5.29%. So the disparity and differences in prevalence of ADHD was due to differences in diagnostic assessment and study methodology for prevalence rates. And indeed, the current DSM-5 shows the prevalence of ADHD in children at 5%. ADHD symptoms tend to decrease in number over time, but severity can persist. A young child, perhaps 4, 5, 6, 7, 8, anywhere from 4 to 9, 4 to 10, may have the greatest number of symptoms: not sitting still, racing around as if driven by a motor, not being able to wait their turn, blurting out answers, poor impulse control, not finishing things, being disorganized, accident-prone. But these types of symptoms can lessen or become fewer into adolescence. Whereas adolescents may not be as hyperactive, they may still be disorganized with their tasks or have trouble completing tasks. They may still have trouble focusing attention, but they're not as hyperactive as the younger children. And adults with ADHD tend to have fewer symptoms as well, but the symptoms can still be functionally impairing. I've put together this table showing the clinical presentation of ADHD across the life cycle. And it's notable to recognize that the DSM-5 has changed its criteria for ADHD. It used to be that the onset of symptoms had to be before age 7, and currently the onset of symptoms must be before age 12. And this was because it could be that a child may have had only or primarily the inattentive symptoms of ADHD, and those can go unrecognized in younger ages in elementary school and may not be recognized until the child gets more challenging work in middle school and high school, and they're more fully assessed. And so that's predominantly one of the major reasons cited for raising the age criteria for 12, that the symptoms need to be present before age 12 and not age 7. And for adults, as we talked about, there are fewer symptoms, and they still could have unstable social relationships. They could be compelled to talk on their cell phone during meetings, for example, and perhaps lose their job or get in trouble at work. They can have difficulty sustaining relationships, and they may be thought of as flaky and not being able to complete tasks. So, as a broad concept, ADHD is a chronic condition. It's a chronic brain disorder, but the symptoms tend to become fewer over time, and each individual needs to be assessed on how functionally impairing that child is. And all ethnicities have ADHD at the same rate and can be diagnosed with ADHD at the same rate. To start addressing the outcomes of ADHD, there have been many studies looking longitudinally at individuals with ADHD on whether they have substance abuse issues and whether they're more likely to have substance abuse issues. And it is clear that individuals with ADHD are at greater risk for substance abuse problems. But it's not necessarily stimulants that they abuse. Cigarettes, alcohol, and marijuana are most commonly abused. ADHD was the second most common diagnosis in youth who abused marijuana in one study by Brooke Molina, who was a collaborator on the largest study of ADHD in the U.S., the MTA study. The first most common diagnosis is conduct disorder. So individuals who abuse drugs and alcohol, have early cigarette smoking, are much more likely to have conduct problems that meet criteria for conduct disorder, and they're more likely to have ADHD. So this points to the fact that children who exhibit conduct problems and academic problems in school really need to be evaluated for ADHD to determine if that is a factor that could make them at higher risk for abusing drugs and alcohol. The Substance Abuse and Mental Health Services Administration of the United States, or SAMHSA, conducts a survey, an annual survey of illicit drug and alcohol use. And this slide shows from 2002 to 2011 the change in cigarette smoking, binge drinking, and marijuana use in youth from 12 to 17 years old. And while you can see that overall substance dependence has decreased from 2002 to 2011, it's by 2 percentage points, and cigarette smoking has also decreased. Binge drinking is less, but marijuana use has been increasing. From 2008, at 6.7% of youth aged 12 to 17 years report using marijuana regularly over a month, versus 7.9% in 2011. So parents, families need to be vigilant about marijuana use in youth in general, not just in youth with ADHD. And the use of psychotherapeutics like Vicodin, benzodiazepines, stimulants used for ADHD has also decreased if you look at the black squares from 4% in 2002 to 2.8% in 2011. So youth still are prone to using illicit drugs, certainly marijuana, and prone to abuse psychotherapeutics. It has gone down somewhat over the past 10 years. Now, the goals of diagnosis and treatment for ADHD need to be discussed with the patient, with the family. Even children can understand when they're performing badly in school. It's easy for them to see when they're getting into trouble more, when they're getting bad grades and other classmates are not getting bad grades, when they're put in timeouts more. And so it's really good to discuss with the child that they're being given medication not as a punishment, or they're being diagnosed or evaluated not because they're bad kids, but just to see if they happen to have ADHD that can be treated so that they can function better in school and that they can have better social relationships with their friends. And the families need to be counseled that they should identify certain goals before starting treatment of ADHD. We want to try to improve educational achievement for adolescents and adults, better outcomes in school, but also in employment, being able to stay at the same job longer. And then the long-term goal is to decrease adverse life outcomes like incarceration, substance abuse, unemployment, and disability. So these are goals that need to be discussed with the individual person with ADHD, whether they're a child, an adolescent, or an adult, and their family members. There is evidence that effective treatment for ADHD can improve academic achievement. This was a study looking at almost 600 medicated versus non-medicated children with ADHD, looking at standardized tests with math and reading from kindergarten to the 5th grade. This was an National Institute of Mental Health funded study, and 90% of the individuals were taking a stimulant for their ADHD treatment. And children who were medicated had 2.9 points higher in their math scores, and children who were medicated had 5.4 points higher in their reading scores. Now, it is significant to note that treatment for ADHD did not make all of the symptoms go away or did not help with the academic scores compared to kids without ADHD, but it did make a difference, and it could improve academic achievement in adolescents and young adults as well. Quality of life suffers when someone in the family has ADHD. It is disruptive to family gatherings. Sometimes parents don't feel like they can take their child to family gatherings. They can't take them to a restaurant and have them sit the whole time. Or sometimes it causes sibling rivalry when the parents are focused more on the child with ADHD and the other siblings feel neglected, and they may act out to try to get the parents' attention as well. There are some studies looking at quality of life with pharmacologic treatment, and I'm presenting this study looking at methylphenidate and clonidine and the impact on family scale versus children receiving placebo, and finding that there was an improvement in quality of life as rated by family members of the children who were taking methylphenidate and clonidine versus children who were receiving placebo. So effective treatment can improve quality of life for individuals and their families. It is important to review the multimodal treatment study, or MTA study, because it is the largest study over the longest time period that we have data for on the outcomes of children with ADHD treated over time. So these children started off, there were almost 600 of them. It was a multi-site study, 6 centers across the U.S. Unfortunately, they were mostly Caucasian boys, so some of the results cannot be transferred to girls and ethnic minorities, but it is still a good look at ADHD over time. So these individuals were stratified into 3 active treatments versus community care. Medication management involved 3 times a day methylphenidate at 07, between 11 and 12, and then again at 2:30 or 3 p.m. The parents and family members got behavioral therapy, parent training. The kids got the behavioral therapy, and the families got the parent training. There was also an arm that got the methylphenidate 3 times a day and the behavioral therapy and parent training. So those were the 3 active treatment groups. And this was compared to just community care, what happens naturalistically. Perhaps the child's teacher says, get them evaluated. The pediatrician says, yes, I think they have ADHD, and they get treated. So that's what it was compared to. And medication was superior to behavioral interventions in this study, although the parents and family members rated behavioral interventions as very helpful and a positive result on the family and on the peace of mind of the family. Now, the positive effects of these results were maintained at 24 months, or maintained at 2 years. After 2 years, they recruited local normal controls. So individuals, let's say if there was a 9-year-old at the Irvine site with ADHD, they recruited a 9-year-old without ADHD from that child's school system to be the local normal control. And then they followed these individuals out for 3 years and then out to 8 years. And at the 3-year follow-up, comparing delinquency and substance abuse from individuals in the MTA study, meaning individuals with ADHD receiving treatment, either behavioral interventions, medication, or the combination, they compared the delinquency and substance abuse to local normal controls. Now, it's of note, there was no control over the treatment after the 2-year period, so they were just followed naturalistically. And what was found was that kids with ADHD just had higher rates of early cigarette smoking, early marijuana use, alcohol use, and higher rates of delinquency like shoplifting, vandalism, than the local normal controls. There was some signal that intensive behavioral therapy decreased substance abuse and delinquency at 2 years, but there was no significant difference at 3 years and beyond from the behavioral interventions. So this information just tells us that ADHD itself is associated with higher rates of delinquency and substance abuse, so we really need to be vigilant and employ treatment all along to try to minimize these symptoms. At the 8-year follow-up, again naturalistically, they were not controlled anymore, but naturalistically, at 8 years, they looked at these same children and asked about incarceration, substance abuse, symptoms of ADHD, and overall outcomes. And what the investigators found was that children with the best response to any treatment had the best long-term prognosis. Could have been any stimulant, non-stimulant, behavioral interventions, but just children who responded well to treatment had the best prognosis. Rates of ADHD were constant at 3 years, but not all of the children met criteria for ADHD into adolescence, and that fits with other epidemiological studies showing that ADHD can decrease in the number of symptoms and adolescents may not meet full criteria. Adolescents had fewer symptoms, but their functioning was worse on 91% of variables tested, like aggression, depression, anxiety. They were twice as likely to have contact with the police or be arrested. 10% had a psychiatric hospitalization versus 1% in the local normal control group. Inattention was the most persistent symptom at 6 years and 8 years in this MTA study. So the hyperactivity does tend to wane into adolescence, and it's the impulsivity and the inattention that's the most persistent symptom. The American Academy of Child and Adolescent Psychiatry publishes practice parameters for psychotropic meds in youth. Many parents and families are concerned about the use of psychotropic medications in their child, in their teenager. But psychotropic medications can be used safely and effectively by following these guidelines. A thorough psychiatric evaluation must be done whenever a child is going to be considered for medications. We need to look at whether they have any comorbid conditions like liver or kidney problems or metabolic disturbances, obesity. We need to see if there's any underlying cardiac problems, because individuals who have underlying cardiac problems like valvular problems or mitral valve prolapse or structural cardiac abnormalities may be more sensitive to adverse effects. We need to get collateral information from all family members, caregivers, even siblings can give good information about symptoms that are most bothersome. The American Academy of Pediatrics recommends evidence-based treatment. So looking at using first line the medications that have the most evidence for efficacy and safety. Planning for short and long-term monitoring is essential, and all of the guidelines recommend that when possible, it is good to get the assent of the child. And most children ages 11, 12, teenagers can give assent for medications. We really want to get the child to agree to the medication trial and to give their feedback of how the medication is making them feel, if it's helping them, what side effects they're having, and that is what is meant by assent. So consent from the parents, but also assent from the middle school child or teenager. Documentation of drug therapy decisions and the rationale for drug therapy decisions is essential, and a specific plan should be outlined for titration, monitoring, and withdrawing ineffective medications. Rating scales are useful for ADHD assessment. Child behavioral checklists are examples of broadband scales that can help gather a list of symptoms, but narrowband scales are preferred. For example, Connor's scale has a parent rating scale, validated scales for parents, for teachers, and even for the individual teenager themselves to rate symptoms. The Vanderbilt assessment can detect comorbid conditions and looking for anxiety, depression, any kinds of tics or conduct problems. So it's good to use these rating scales before starting treatment and after starting treatment to assess the impact and efficacy of treatment. Many parents and families ask about complementary or alternative therapies, CAM, and the bottom line is these should not be used in place of effective evidence-based medications. None of them have been shown to be as effective as stimulants or even non-stimulants for managing ADHD. That said, it's good to be open-minded about the impact that some CAM treatments can have on improving ADHD symptoms. There is mounting evidence that if a child is deficient in iron, supplementing them with iron can improve ADHD symptoms and allow for lower medication doses. Omega-3 supplements may have possible beneficial effects. It's good to counsel parents to use a USP certified product to make sure that there are not unacceptable levels of mercury or other impurities in the supplement. Many parents believe that sugar and artificial sweeteners make their child's symptoms worse. This has not been borne out by the evidence, but certainly it can't hurt to adopt healthier meal plans, including a good balance of protein and fiber and fruits and vegetables. Artificial food coloring, such as found in hot dogs and lunch meats and things, have been purported to worsen ADHD symptoms in some children. Evidence is mixed, but it certainly doesn't hurt to avoid these things if parents are noticing problems with them. Biofeedback has not been demonstrated effective, where the child looks at a computerized images to try to change their brain waves to help with attention and impulsivity. This has not been shown to be effective. Behavioral interventions are effective. In fact, the American Academy of Pediatrics recommends behavioral interventions for 4-year-olds who meet criteria for ADHD, and even some 5-year-olds. They recommend giving a trial of behavioral interventions before going to medications, except in severe cases where it's really clear if a child has a genetic-based ADHD and they're not learning anything because of it, then you may go ahead with medications. But positive rewards for good behavior, parent training, consistent limit setting, routine can all be helpful behavioral interventions for decreasing ADHD symptoms. It can certainly lower parental stress, and some studies show you can get by with a lower medication dose. Now, when it comes to evidence-based treatment for ADHD, stimulants are first line. They are the most effective treatments. They have been studied for ADHD since the 1940s and 50s. Used more extensively in the 1990s and 2000s when more rigorous trials came out. And stimulants are pretty much divided into 2 categories, the methylphenidate, dexmethylphenidate category and the dextroamphetamine, mixed amphetamine salt category. They are considered comparable in efficacy. If one stimulant category does not work for a child, adolescent, or adult, then the other stimulant category can be tried. If methylphenidate does not work at a wide variable dosing range, I wouldn't go to dexmethylphenidate though. I would go to a mixed amphetamine salt product, and vice versa. If mixed amphetamine salts are ineffective at the maximum tolerated dose, I wouldn't go with dextroamphetamine. I would go to a methylphenidate product. So you can see that the number needed to treat is quite low. 2 out of 3 children or adolescents or adults can get significant therapeutic benefit from a stimulant trial. Once daily stimulant products are preferred and are recommended in practice guidelines from the Journal of the American Academy of Child and Adolescent Psychiatry and the American Academy of Pediatrics, because once daily product formulations allow for better adherence, compliance to treatment, and less hassle of a child having to be stigmatized for taking medication during the school day. And there's less potential for drug diversion because medication doesn't have to be administered in the school day. There are many different product formulations of once daily stimulants, and they can be divided into the 10 to 12 hour formulations versus the 8 to 10 hour. Concerta is one of the longer duration of effect medications. It has an outer coat and then 2 inner coats. And most individuals get a 10 to 12 hour duration of therapeutic effect. Metadate CD usually lasts a little bit shorter, around 8 to 10 hours. It has 30% immediate release beads, 70% extended release beads. Ritalin LA is also around 8 hours, 8 to 10 hours. Focalin XR lasts about 12 hours, sometimes 10 hours, but mostly 12. And both Ritalin LA and Focalin XR have 50% immediate release stimulant and 50% extended release stimulant. Adderall XR is mixed amphetamine salts. It's got a 50% immediate release, 50% extended release beads. And Vyvanse is lisdexamphetamine. It's a prodrug that's converted in the gut and to the active form of dextroamphetamine. And it has a slower onset but a long duration of around 12 hours. Methylphenidate is available in a transdermal patch called Daytrana, and it is necessary when using this formulation to apply it to a clean, dry, hairless area. It's recommended to apply it on the hip so the child can't mess with it during the day. It has an onset within 2 hours of applying the patch, and it avoids the first pass effect. So it's important to know that one shouldn't switch. Let's say if a child is taking 10 milligrams 3 times a day of immediate release methylphenidate, one should not switch to a 30 milligram patch. You have to start over with the patch because the patch goes directly into the bloodstream. You would start at the 10 milligram patch and then titrate weekly to response. There's 9 hours of wear time from a single patch, and then you can get the duration of effect when you take off the patch after 9 hours out to 12 hours. So you can get a full school day covered with 9 hours of wear time. Lisdexamphetamine is the prodrug of dextroamphetamine, and so it requires conversion of the active form in the gut. And I've listed on this slide the conversion of mixed amphetamine salts, abbreviated MAS, to LDX, the abbreviation for lisdexamphetamine. So about 10 milligrams of mixed amphetamine salts is roughly equivalent to 30 milligrams of lisdexamphetamine. Now there is a longer onset of effect. It may take 1 to 2 hours for the onset as opposed to a half an hour to an hour with other formulations. There are some studies showing that it has some less drug-liking effect at the lower end of the dosing range at doses anywhere from 20, 30, 40 milligrams a day. It's particularly at 20 and 30, but when you get up to the 50 to 70 milligrams a day, there is still strong drug-liking effects, and it still has a risk of abuse, particularly in individuals with substance abuse problems. It is approved, stimulants are approved, including lisdexamphetamine for children, adolescents, and adults. The newest formulation of long-acting stimulant is methylphenidate powder. It's a long-acting suspension known as Quilivant XR. It only has one double-blind controlled trial in about 45 children aged 6 to 12 years old. That's the study that got it approved. So it's more well studied in the younger kids. It's recommended to start it at 20 milligrams in the morning, and it lasts 8 to 12 hours for a duration effect of 8 to 12 hours. It must be reconstituted by a pharmacist and is stable for 4 months after it's reconstituted. So in addition to setting the goals of treatment and discussing that in counseling parents and families, we need to talk about stimulant side effects. And the two most common stimulant side effects are upset stomach or stomach pain and insomnia. Roughly 20 to 50% of individuals experience upset stomach or insomnia from stimulant medications. Now, I've listed some management strategies. Sometimes taking the medication on a full stomach or lowering the dose with slower titration can help with upset stomach. But realizing that stimulants, the onset of effect is faster when there is no food in the stomach. So you'll get a faster onset of effect without food in the stomach, but you might get more stomach irritation and certainly anorexia or suppression of appetite. Insomnia tends to get better over time. It's worse in the first couple of weeks to a month after starting stimulant therapy, but giving the dose as early in the day as possible or administering a sedating medication in the evening can be helpful, like the sedating antihistamine, cyproheptadine, which can also increase appetite, or the alpha-2 adrenergic agonist medications like clonidine or guanfacine can be given in the evening. Melatonin has been shown effective for managing insomnia in children with ADHD taking stimulants. You give it 2 hours before bedtime, like if they go to bed at 9, you give it to them at 7 p.m., and usually 1 to 3 milligrams of melatonin is effective. Headache, you get some tolerance to the headache over time, but it doesn't tend to be as common as the upset stomach or insomnia. Tics happen in about 1 to 9% of individuals taking stimulants, and they may require lowering the dose, changing meds. Of the stimulants, methylphenidate is the least likely to worsen tics. Amphetamine salts are more likely to. Atomoxetine may or may not worsen tics, and clonidine or guanfacine can improve tics. If the child becomes dysphoric or irritable, irritability tends to be more common in very young children taking stimulant, like 4 and 5-year-olds. But if a child becomes more irritable or dysphoric, you got to reassess the diagnosis, possibly even change drugs. Hallucinations have been reported in 1% of individuals with ADHD taking stimulants, and then we need to DC the stimulant, reassess diagnosis. And one sign that there is too much stimulant medication on board is if the child is mechanical, over-focused, zombie-like, and this requires lowering the dose. Many families are concerned about growth effects from ADHD medication. Growth effects are usually minimal and may not affect long-term growth, although the MTA study did show some effect of growth for children that stayed on their stimulant. There was a decrease in height in 1 centimeter per year over 1 to 3 years of continuous stimulant treatment, and there was a decrease in weight of 3 kilograms in weight the first year and less weight decrease the next year. And this normal growth was taken into account in calculating these differences in height and weight. So stimulant manufacturers had to add this potential effect on growth to the package insert of all stimulants being used for ADHD. So strategies for trying to minimize growth effects are possibly, not using the stimulant when the child is outside of school, although this can, result in problems with socialization and problems with self-esteem if the child notices their symptoms returning. Sometimes lowering the stimulant dose can be helpful, but then there might be a relapse in symptoms. Combining behavioral therapy may be helpful. Giving favorite foods when stimulant effects are low is a strategy for minimizing anorexia, improving weight gain. Atomoxetine has less effects on growth than stimulants. Certainly the alpha-2 adrenergic agonists like guanfacine and clonidine do not have effects on growth. Bupropion does not have growth suppression or delays of growth. There are several non-stimulant treatment options, some with FDA approval, but none of these are considered as effective as stimulants. In fact, a controlled trial studying atomoxetine versus Concerta showed that Concerta, the 3-pulse Oros delivery of methylphenidate, was more effective than atomoxetine in treating ADHD. But atomoxetine or Strattera is FDA approved for all ages down to 6 years old. It takes 2 to 4 weeks for the onset. It certainly has less insomnia, less growth effects. It has a greater risk of increasing pulse, as shown by the study comparing the Concerta to the atomoxetine. And rarely hepatic toxicity has been reported, and even liver failure. So that should be included in counseling a patient and family and giving them the signs and symptoms of liver problems, weakness, fatigue, easy bruising. Bupropion is not FDA approved for ADHD. It does work, however, particularly for adolescents and adults. There are no good studies showing bupropion works for ADHD in prepubertal kids. Do not allow use in individuals with seizure disorders because it certainly can lower the seizure threshold, making seizures more likely. It has a risk of insomnia as well. Clonidine and guanfacine are both FDA approved for children and adolescents 6 to 17 years old. The extended release formulations of clonidine and extended release formulations of guanfacine are the FDA approved formulations, although the immediate release formulations are also given. It is important to note that studies show they're not as effective in heavier children or older adolescents. It could be a dosing thing, that they need a higher dose to be effective in older children or heavier children or adolescents. There were reports of sudden unexplained death in children and adolescents taking stimulants for management of ADHD. And because of these reports, studies were commissioned by the Agency for Healthcare Research and Quality. The federal government funded these studies to look at whether stimulants do indeed cause a higher rate of adverse or serious cardiovascular abnormalities. And fortunately, in looking at the data, there was only 3.1 per 100,000 person years of serious cardiovascular events. And this was not found to be any higher than in the general population. So looking at the graph, you can see that non-users and former users had a similar rate of adverse cardiac events and cardiovascular events compared to those who were current users of stimulant medications. So comorbidity is a significant factor in guiding treatment and selection of drug therapy for individuals with ADHD. And that's why I recommend that if a child is thought to have ADHD, that they get evaluated by a behavioral developmental pediatrician or a child and adolescent psychiatrist, someone who works day in and day out with children and can detect differences in symptoms and attribute them to whether it's related to a primary anxiety disorder or depression or substance abuse or Tourette's or oppositional defiant disorder. I've listed the 1-year prevalence of these comorbid conditions in individuals with ADHD. It is true that if the child has ODD or conduct disorder, they're at higher risk for substance abuse, so that needs to be taken into account. Stimulants can sometimes make anxiety worse, so that needs to be taken into account. Not always, though. The rate of bipolar disorder with ADHD is unknown because it can be challenging to detect the difference between ADHD and bipolar disorder. A main difference is bipolar disorder tends to be episodic, with episodes of impulsivity and episodes of acting out and mood swings, as opposed to ADHD, the impulsivity is more of a constant, and inattention can be more of a constant. I encourage you to recommend chad.org for patients and families that want to learn more practical information about ADHD and its treatment. This is the cover of a publication that highlighted comorbidity in ADHD. It is clear that ADHD more frequently exists with other conditions rather than on its own. And it's good to look at which condition is the most functionally impairing and treat that condition first. For example, if depression and ADHD coexist, but the depression is worse, it could be that the inattention is related to depression, so you treat the depression and the inattention may improve. In anxiety and ADHD, it could be that the ADHD is making the individual anxious, and so treating the ADHD can improve anxiety in some individuals. So it doesn't always worsen anxiety, but so looking for that and looking for which condition is more problematic and treating that, and then if there's residual symptoms of the co-occurring condition, treat that co-occurring condition. Now that ADHD and autism spectrum disorder can be diagnosed concomitantly, it's good to know that stimulants may worsen the repetitive movements and obsessive compulsive symptoms in individuals with ASD. And individuals with ASD are more seizure prone too, and so stimulants can lower the seizure threshold, something to keep in mind. If it's not clear whether they have bipolar disorder or ADHD, but it certainly seems like they have episodic mood swings and impulsivity and rapid pressured speech looking like bipolar, it's good to stabilize the mood first and then consider whether ADHD needs to be treated. There's high comorbidity in adolescents and adults with ADHD as well. Anxiety disorders tend to be even more prominent in adults with ADHD, followed by mood disorders, then impulse control disorders, and substance use disorders. SSRIs have the most evidence for managing depression and anxiety in youth. I've put this table together just to show you FDA approvals down to different ages in youth, and to show you that fluoxetine can elevate amphetamine levels. So if a child, or atomoxetine levels, if a child is taking mixed amphetamine salts or atomoxetine, they could get more of a pronounced effect if they're also taking fluoxetine. A pharmacist may see that a child with ADHD is also prescribed an antipsychotic like risperidone or aripiprazole or quetiapine. It's important to note that antipsychotics are not for core ADHD symptoms, but they are for associated aggression. They can help with conduct disorder, and every now and then we'll get an extremely aggressive youth. They're with ADHD, they're stabbing their siblings with cutlery, or they're engaging in self-injurious behavior, and sometimes they need short-term antipsychotic. I've included a website for you, Treatment Recommendations for Aggressive Youth, and it includes a whole algorithm for managing aggression in youth that includes using antipsychotics. ADHD does confer a 2 to 7 times greater risk of substance abuse, and so it is necessary to be vigilant and mindful of whether a young person or adult is actively engaged in substance abuse. If they are, or they're in recovery, it may be best to try a non-stimulant treatment option without abuse potential, like atomoxetine or bupropion. Clonidine or guanfacine can be useful for middle school age children or some smaller high school age children, and they do not have substance abuse issues, but their clonidine and guanfacine have not been found effective in adults. Atomoxetine is a selective norepinephrine reuptake inhibitor. It is effective for children, adolescents, and adults. It does not have abuse potential, has less growth effects. It may not worsen anxiety. It has a longer onset of therapeutic benefit, though, and its adverse effects are similar to stimulants. It's got more sedation, though, and slightly higher increase in heart rate compared to stimulants. It's necessary to counsel on the rare hepatotoxicity and the rare treatment-emergent suicidality. And it got this warning because it is structurally related to antidepressants. So atomoxetine was first marketed as an antidepressant and found not to be effective for depression, and then it was found effective for ADHD. Bupropion is a antidepressant that has norepinephrine and dopamine enhancing effects. It is less effective than tricyclic antidepressants like amitriptyline or imipramine for ADHD, but it is safer. I rarely see TCAs used for ADHD these days. The dosing, usually starting at the low end of the dosing range, if immediate release is being used, can be 50 or 75 milligrams twice a day, or 100 milligrams of the sustained release, or 150 milligrams starting dose in a larger adolescent or adult. Bupropion has not been studied extensively versus stimulants, but it's definitely more effective than placebo in adolescents and adults. Side effects include nausea, tics, rash. It should be dosed in the morning because it has a significant risk for insomnia, and it should not be given in individuals with active substance abuse issues, because if they drink alcohol or use cocaine or crack or other abusable substances, they may be more likely to have a seizure. Guanfacine extended release, or Intuniv. It is more selective for the alpha-2A receptor compared to clonidine. It has less sedation and dizziness. These are good medications for kids who cannot tolerate the insomnia or upset stomach of stimulants, or who may need some additional sedation. Guanfacine extended release is usually started at 1 milligram in the morning, and then it can be increased every week to every 2 weeks to the usual effective dose of 4 milligrams of the extended release tablet. And it usually has some effect by week 2, but can take 4 weeks before you see significant therapeutic benefit. Side effect monitoring should include looking for dizziness, orthostasis, excessive sleepiness, or constipation. Guanfacine tends to cause less sedation and less dizziness compared to clonidine, because it is selective for the alpha-2A receptor. Stimulants are effective, but they are our first-line treatment, but sometimes they are not effective enough. And there are some studies showing that adding an alpha-2 adrenergic agonist can improve the response and increase efficacy of the medication therapy. So one study looking at 75 6 to 17-year-olds looked at individuals who had residual symptoms of ADHD after 1 month of stimulant, and they added the guanfacine XR and found that they had significant improvement and less insomnia. You can see on the scales, the ADHD rating scale significantly improved when the guanfacine was added. Clonidine is available in extended release formulation, that is the FDA approved form, while the guanfacine can be given once a day. If clonidine is used in monotherapy, it should be given twice a day because it has a shorter duration of effect. If it's being used as an adjunct, it may be able to be used once a day. It's more sedating than guanfacine, and it tends to have a bit more bradycardia as well. We want to counsel that there's the possibility of nightmares with clonidine, sometimes with guanfacine as well, but more reports with clonidine. And caution if the child does have underlying cardiovascular abnormality. So the clonidine and guanfacine can lower blood pressure, lower pulse, and we really want to use them with caution in a youth with underlying cardiac abnormalities. So ADHD medication counseling. It is necessary to compare the agents for the patients and families, and so that they know, do they want to try the most effective treatment like stimulants, or which side effects are they most concerned about? And that can help with choosing the right medication for the right individual. Stimulants are the most effective. They tend to work within 1 to 2 hours of an effective dose. The other agents can take 2 to 4 weeks for therapeutic benefit. When stimulants are used, the once-daily stimulants are preferred to improve adherence and decrease diversion. It's never good to abruptly stop treatment, particularly with the guanfacine and clonidine, because there can be rebound high blood pressure that could happen. All adverse effects can be managed by taking with food, by adjusting dosing time, by changing agents, so that's a message we need to impart to patients and families. We want to pay attention to drug interactions. For example, fluoxetine can elevate levels of atomoxetine and mixed amphetamine salts. Atypical antipsychotic like olanzapine or quetiapine, if they're taking that for aggression, if they're also taking clonidine or guanfacine, you can get additive sedation. We want to have vigilance for all individuals with ADHD for whether they are actively abusing drugs and alcohol, because people with ADHD are more prone in general, and we may need to select their treatment based on this. To summarize, children of all ethnicities can meet criteria for ADHD when consistent methodology is used and the consistent DSM-5 criteria are used to evaluate ADHD. Then all ethnicities have a similar prevalence of ADHD, and all can benefit from treatment in improving academic performance, improving socialization, self-esteem, growth and development. Thorough evaluation by an experienced clinician is best to evaluate for comorbid conditions. Biopsychosocial treatment or multimodal treatment is recommended with behavioral interventions, parental education and training, considerations of vitamin deficiencies or CAM therapy when desired by the families. We want to recommend evidence-based pharmacotherapy and monitoring and counseling on ADRs and management. It has been my pleasure to present this information to you today, and I look forward to your questions.